Dear ladies and gentlemen, my name is Marco CAVERSACCIO. I'm from the University Hospital in Bern, and I will speak about Bern experience with robot cochlear implantation. Disclosure and acknowledgement, I was supported by our colleagues at the ARTORG-Center, Inselspital, Swiss Confederation, EU project, and Medal Company. When we speak about robot, first of all, we must know what is mean a robot. And I will speak especially today about robot-assisted surgery and not about full automation or high automation or conditional autonomy. When you look about the state of the art, I must mention certainly Professor Labadie from the Nashville University and Vanderbilt University for stereotactic cochlear implantation, where he has performed 2014 9 cases. Another possibility is what was presented 2016 with a prototype was the mastoidectomy by limb. Another possibility is to go inside, this means in the inner ear auditory canal, was presented by Dylan 2017. The last development was a machine presented by Robotic from France and by Nguyen and Professor Sterkers to look about CI insertion, not the holy way to go inside the cochlea, but especially the last step inside the cochlea. And he presented a new paper about restoration of high frequency using this machine of Robotic. Another presentation from another group of France, they used a ROSA robot and they presented 5 consecutive patients with this minimal invasive fully robot assisted cochlear implantation in humans. Another group is working in Hanover about Robotic. Until now, I have not seen a presentation or real life in human at the moment, but they will certainly come in the future in the OR. Now I will present a little bit the robotic cochlear implantation in Bern. What is very important is a planning system. Then we have the robotic middle ear access. Then it's possible to go inside the robotic inner ear access. And last but not least, step 4 is robotic electrode array insertion. We have presented this first time in 2017 by ACTA as well by Science Robotics. We have performed between 2016 and 18 a clinical trial in Bern, a prospective non-randomized single-center study. We have had the approval from the Ethic Commission, Swissmedic. The objectives were to demonstrate the feasibility of RCI, validate clinical workflow, validate system and procedure safety mechanism, and data collection for safety and workflow optimization. We include cochlear implantation, age more than 18 years, and sufficient facial recess size. What is most important is to plan this procedure. This means a standardization and selection of optimal electrode array, estimate the conductive duct length, and select appropriate array. And this is very important. The challenge remains to have a high accuracy between the chorda and the facial nerve. As you know, this will be about 2.5 to 3 millimeters, what you can see here in blue. Otherwise, it's impossible to do this surgery when you use a drill bit, then it's more than 2 millimeters. The safety measure is to look about the packing data to go to the facial recess. This is the first step. The second step is goes through this facial recess. The third step is to enter the middle ear and to the inner ear. And last but not least, step 4 is to go inside the cochlea. There we plan this on the safety measure on this auto-plan system, and we can measure exactly the trajectory length, the margin to facial nerve, to chorda tympani, to external auditory canal, as well to the star-based surgery. Then we have developed this together with Medal and calcination, this 3D ear model, where you can see here in yellow is the facial nerve, in orange is the chorda tympani. Here you can measure the trajectory parameters, the distance to stapes, here 0.3 millimeters, the in-plane angle 11.9 degree, or the out-plane angle is 24.6 degree. Here you can see the contact points of C1 to C12, and you can see the insertion degree, where in this case was 517. Another possibility is to have in the future an automatic modular axis detection in CT, where we have published this last years to look about this new feature in the autoplan, because until now it is again semi-automatic. Another possibility to measure the estimation of the cochlear implant electrode array insertion is to do this by impedance. This can be also the future. Perhaps you can exclude also in the future a postoperative CT scan or a cone beam CT. Now we have a look on the first operation, first in man. This was 2016, and I will present you this procedure. This is the University Hospital in Bern. We have worked together with the Center of Biomedical Engineering Research at the University Hospital of Inselspital. Here we put some screws inside. These are the fiducial markers. Then we make a CT scan. This is a Cogan syndrome. You can see also a little bit liquid in the mastoid. Then we make this segmentation to segment the facial nerve, and the chorda is in orange. And then we have this model. Then we go to the OR. You have some pads. It's not a Mayfield. You have the measurement of the facial nerve. And here you see the robot with the Axios camera. And here we present now, the first thing is to make a verification, a matching. It's like for navigation system to look. Here is the entrance point in blue. And we can also see in red where we put an antenna. It's like a dynamic reference base. This is here. I put this here. And all the instruments are equipped with light emission diodes. Here you see the entrance with a small retractor, this incision. And here we make with the trocar a small hole to put in our antenna, our trocar with the light emission diodes. And then we make again a verification that we have a high accuracy before we start the operation. It must be normally below 0.5 millimeter. Here we have the joystick to move on the robot system. It gives a trajectory line, and you have a 1.8 millimeter drill. It goes down. It's clear to use water, that it's not heat up. Then we take away some screws, and we make during the operation a cone beam CT to know exactly where we are, to have this as safety procedure. Here you can see the road inside, and we put again the verification on. Now we continue on this way through the facial chorda recess, and this is important because we use also this stimulator, facial nerve stimulator. Like this, we can measure here all the EMG, the results of this one, and then we continue with small PEC data to continue through this facial recess to go inside the middle ear. Here we measure again to be sure that we are not too near to the facial nerve. And now we can also measure here the endoscope, and we can see here the dummy that we can use it, and we continue now to open here the cochlea. Here we take one of metal company's electrode, and we put here in this tube the electrode. It's a little bit floppy, but it has like a shoe on the tube, and we can enter here with this electrode. Then we take away this tube. Last but not least, we can measure the impedance. There you can see here. And we will finish then with the operation here to put in, here we make postoperative cone beam CT to look if everything is okay. Good. Are the results where we have. Here is on patient 3. We have on one side is a conventional approach with the mastoidectomy. Then we have the drilled tunnel with robotic approach. As you can see, the right side with this drilled tunnel on a 3D presentation. Here we have a patient number 6. You can see on one side was operated with mastoidectomy, and on the other side with this tunnel procedure. Here are the summary of the results where we have. This mean we have facial nerve distance. The difference was about the results 0.55, and to the target error was below 0.5 was 0.29 plus minus 0.13 millimeters. Now the duration of the procedure, where you can see the 7 first cases, we have between 4 hours and 5.5 hours. This was especially the surgical planning, the patient preparation, as you can see, more than 1 hour. We have the study protocol. This was important for the ethical commission, the intraoperative imaging analysis, the patient transport and CT, the fiducial screw implantation, where we put this in local anesthesia. What is also important when you use a robot surgery is perhaps also to change a little bit on the cochlear implant design. And they have metal have made a reducing of 40% of the lead diameter. As well, the lead length was reduced by 26%. Here you can see a good result of patient 6, one to use one of these custom-made implants. And this is very nice to see it, that it works. We have also looked about the children, if it's possible to make operation 6 months to 5 years. We have also published this last year. As you know, the skull is not so easy to use also the different cues because of the length, so, as well as for the size. What is also important, they change during growth, especially also the facial recess, it will be bigger. We have a change of the cochlear angle, as well of the round window angle. And this is important perhaps also for the future, to use a robot system also for children or young children. Now, 2020, metal with calcination received a CE mark for the middle and inner ear approach, and the name is HERO now. We are working also on the clinical trial now with this CE marked robot system. As you can see, it's more exclusive that we can use. It's still with a camera, you know, for the navigation to control the robot system, but it's still working with the screws to have this high accuracy of the system. I will quickly show you now a robotic cochlear implant with the inner ear approach with the HERO system. What is important is especially to make this whole procedure is this 1 millimeter on the tip of this drill bit that we can open the inner ear. Here you can see we go to the round window and we open this with this diamond burr to open here the inner ear. And now we can open here, if you see the round window, the membrane, and with the endoscope, we can insert now the electrode inside the inner ear. And this is new, this is this new inner ear approach. What's next? We're thinking about to use perhaps in the future a multi-port approach. This means on one hole perhaps to use with the endoscope, and on the other side to insert with the guide tube the electrode array. As you can see, it's very narrow, it's very difficult to use this, and perhaps we must know more about the light source also for the endoscope, perhaps in the future. The question remains is especially what's happening in the future. We have normal 10 human and 1 robot. As you know, 30 years ago was 1 man or 1 surgeon and 1 goal. What we have is at the moment 1 team, 1 goal. This means we need a lot of human resources at the moment, especially for planning and to have a high accuracy for using the robot system. And as you know, a robot system must be better than a human. And this is a big challenge for everyone. As general conclusion, I can say surgical robots are promising, but require thorough preoperative planning and postoperative outcome assessment in the future. The application field at the moment is mastoidectomy, especially cochlear implants, double surgery, petrous bone apex, inner auditory canal. What we have is in different countries regulatory hurdles, economic issue because it's expensive, and the question remains of clinical usefulness. Last but not least, I have 2 questions. Question 1 is, what can do the robot from Bern? A, assist surgeon. B, make a nonlinear tunnel. C, is autonomous. And D, adjust trajectory during procedure. This is a question type A. This is mean only 1 answer is right. Second question, what is the greatest danger to work with the robot to perform a cochlear implantation? A, enter the middle ear. B, touch the facial nerve. C, bleeding. And D, evasion of endolymphatic fluid. Again, only 1 answer is right. I give you now the answer. For question 1 is A. For question 2 is B. I thank you for your attention and wish you a very nice day. Thank you very much.